Ashok? Yeah, it's fifth episode of this series. We are doing pre-Vairog for the month. I'm sure you know the concept now by now, because you have already been shared the guidelines and all that. It's my pleasure to introduce our judges today, who don't need any introduction. Dr. Vikas Agash, who has taught us also. And he's one of the well-known trauma surgeons and infection specialists. So he will be judging you today. Besides, we have Dr. Harshad Argekar, who was there earlier also.
Thank you.
He is also a trauma surgeon professor in Cooper Hospital. And Dr. Ashish Fadnis, who is again a well-known surgeon from Jupiter Hospital, Thane. These three will be judging you today. And I'm sure you know the basic guidelines. You have to stick to timing. You have to present during that, and then be followed by question answer session. So back to Ashok, I think.
Yeah. Over to Neeraj, Dr. Neeraj Bijlani, Secretary of BOS, for introducing the candidates today.
Yeah, hi. Good evening, everyone. So welcome to the terrific trauma session number 2. And this is, there are going to be 3 presenters today. So hopefully one of them can become the rising star of the future. So the first presenter is going to be Dr. Rudra Prabhu. He is going to talk on surgical approaches for radial head fractures, current techniques and outcomes. The second speaker is going to be Dr. Shahrukh Khan. He's going to talk on humerus shaft fractures, plate fixation versus intramedullary nailing. And the third speaker is going to be Dr. Vasav Somani. He's going to be speaking on management of Monteggia fractures, surgical techniques and outcomes. With this, I will hand over back to Ashok to start the program.
So thank you, Dhar sir and Neeraj, and we'll start the program now. I'll invite Dr. Rudra Prabhu to start sharing his presentation. Meanwhile, each candidate has 8 minutes to present, followed by question and answer from the judges. So Rudra, you can start. I'll be timing the presentations.
Yes, sir. Is my screen visible?
Yes. And you're audible. You can go ahead.
Good evening, everyone. My name is Dr. Rudra Prabhu. I'm an assistant professor currently working at KM Hospital. I would like to thank the Bombay Orthopaedic Society for giving me this opportunity. My topic for today is surgical approaches and current techniques for managing radial head fractures. So why is the radial head important? The radial head is an important stabilizer of the elbow against valgus instability, especially when the MCL is incompetent. It is responsible for 60% of the total load transmission across the elbow, and it is a marker for associated injuries of the involved extremity. The objectives of my presentation would be to review the current surgical approaches and current techniques for managing these fractures. I've included PubMed indexed original articles, review articles, as well as meta-analysis in this presentation. Starting with the basics, the Mason-Hotchkiss classification is one of the oldest classification of radial head fractures. However, it has stood the test of time. It includes 4 types: non-displaced, displaced, comminuted, and the 4th one is when there's an associated elbow dislocation. The AO classification divides the radial head fractures into extra-articular, partial articular, and complete articular fractures. The associated injuries with the radial head fractures. In a study by Van Diet et al., the incidence of associated injuries in the retrospective analysis of 333 cases was 39%. The associated injuries could be MCL or NCL injuries, or the more dangerous cerebral triad of the elbow, or the less common Essex Lopresti injury or isolated coronary fractures. Coming to the surgical approaches, there are mainly 4 well-known surgical approaches for radial head fractures: the Kaplan, the Cocker, the limited Cocker, and the EDC split, which is the extensor digitorum communis split approach. The Kaplan approach uses the interval between the extensor digitorum communis and the ECRB, while the Cocker approach uses the interval between the inconius and the extensor carpi ulnaris. The advantages of the Kaplan approach is that there is less risk of injury to the LCL, while with the Cocker approach, there is less risk of injury to the posterior introitious nerve. However, the Kaplan approach is proximal to the posterior introitious nerve, whereas the risk of injury to the LCL with the Cocker approach is more. This is a study which was published in 2019, which compared the Kaplan approach and the Cocker approach in the treatment of radial head fractures. It used the 3D digitizer to measure the visible surface area, and as per this approach, the surface area of the radius visible by the Kaplan approach was the maximum. The Kaplan approach also offered the exposure of the coronoid when it was extended proximally. This is a diagram which compares the area which is visible by each of the three approaches, and it is visible in the Kaplan approach provided the maximum visualization. The authors concluded that the Kaplan approach is the most extensile. It preserves the LCL as well as helps in visualization of the coronoid. This was a study published in 2014 in JBJS, which compared the extensor digitorum communis and the cocker interval. The authors concluded that the EDC split approach provided more visualization of the anterior half of the radial head, and it was also associated with lesser risk of injury to the lateral ulnar-collateral ligament complex. Another approach, which is less commonly used, is the posterior approach, which utilizes the Boyd's interval between the conus and the ECU. The advantage of this approach is that the radial head, olecranon, as well as the coronoid fracture can be addressed, and there is lesser risk of injury to the posterior introitious nerve. This is an article which is published in 2023, which states that the posterior approach is a good approach for managing radial head fractures when there are associated fractures such as the olecranon and the coronoid. Coming to the management of non-displaced fractures is hematoma immobilization as followed by immobilization and non-sleep for 2 days. The important thing to note here is that early mobilization is very essential because shorter period of immobilization are associated with better patient-reported outcome measure scores. This is evident by the two articles mentioned in this slide. The management of Mason type 2, a stable partial articular displaced fractures, is a bit controversial. This is an article published in 2014 by Yu et al., where he compared 30 cases managed conservatively, while 30 cases were managed with open reduction internal fixation. All the patients included had isolated partial articular radial head fractures, which were displaced more than 2 mm but less than 5 mm. The authors concluded that there was no clinical benefit with ORIF at a short-term follow-up. Another study published in 2020 in the Journal of Shoulder and Elbow Surgery concluded that open reduction internal fixation as well as conservative treatment both offer satisfactory functional outcomes when used for the management of Mason type 2 radial head fractures. Age and activity level is important to be considered before treatment, and the incidence of osteoarthritis was higher in the conservatively managed group. This was a meta-analysis published in 2019 regarding comminuted fractures of the radial head. The authors concluded that the radial head arthroplasty was the most effective treatment, while the radial head resection was the safest choice for minimizing post-operative complications. 12 comparative studies as well as 1 randomized control trial were included in this meta-analysis. This article published in 2015 regarding radial head resection concluded that radial head excision was a good option in elderly patients. The patients included were 30 patients and they were more than 65 years old and all had comminuted radial head fractures. To summarize, all type 1 fractures can be managed conservatively. Type 2 fractures with no block to rotation, it is debatable conservative versus ORIF. If there's a block with rotation, ORIF is preferred in type 2 fractures. In type 3 fractures with 2 to 3 simple fragments, ORIF can be done. However, if there are more than 3 unstable fragments, radial arthroplasty is the preferred treatment. Coming to osteosynthesis, screws or plates. The problems with the radial head plate include risk of violating the safe zone, increased risk of injury to PIN, as well as the need for implant removal. What is the solution? Low profile screw fixation. This technique uses screws to fix the head to the neck. The advantages include lesser implant irritation and lesser need for implant removal. This biomechanical study published in 2019 compared 3 techniques for fixing radial neck fractures. The authors concluded that the crossed screw construct was optimal for Mason type 2 fractures, whereas the plate was associated with the least stiffness. Arthroscopy offers excellent visualization but requires expertise. This is a study published in 2023 which compared arthroscopic reduction versus open reduction. It included 32 patients, the mean follow-up of 10 years. The authors concluded that arthroscopy was associated with a lesser incidence of postoperative stiffness. It is a safe and reproducible procedure but requires a longer learning curve. In cases of radial head fractures which are comminuted and not fixable and associated with posterolateral instability, valgus instability to MCL injury, or axial instability due to intraosseous membrane injury, radial arthroplasty should be preferred as this treatment offers stability as well. To conclude, each surgical approach should be individualized as per the fracture configuration and the associated injuries. maintain elbow function by restoring ulnar humeral joint. It is important to re-establish elbow stability, and the management should be decided by assessing all aspects: stability, combination, articular depression, as well as the associated injuries. These are my references for the presentation. Thank you very much for your patient listening.
Thank you, Dr. Rudra. You finished with 4 seconds left. That means optimally utilizing the time given. So I'd like to invite the judges now for their questions. Agashe sir, you can go ahead with your questions.
Yeah. Hello, Rudra. First of all,
Hi, sir. Good evening, sir.
good evening. Very nice presentation. Really appreciate.
Thank you, sir.
What new did you learn as regards the approaches are concerned? And when would you use Kaplan and when would you use Cockers? And when will you do extensile or modified Cockers and modified Kaplan?
Yes, sir. What I've mostly seen while managing radial head fractures is the Cocker approach. But the important point which I understood after reviewing the literature is that Kaplan offers more visualization as compared to the Cocker's approach. I would prefer the Cocker's approach when there is associated injury to the lateral ulnar collateral ligament, because it provides visualization of the complex and it will help in fixation of that complex. On the other hand, if the fracture is more anterior, the Kaplan approach, there is associated risk of injury to the posterior interosseous nerve. So that is one thing which needs to be kept in mind, as the approach is more anterior as compared to the Cocker's approach.
So anything that is given in this paper specifically to avoid injury to posterior interosseous nerve? They mention it time and again.
The standard principle of keeping the arm in pronation, forearm in pronation, that is to be followed all the time while avoid injury to the nerve.
And then if you want to extend it, how would you do that?
Extension of the
approach. Suppose you want to put a plate and you wish to
it can
extend the approach.
It can be extended distally, sir, but usually it is not extended more than 3 to 4 centimeters below the radial neck, because that is the point where there is the greatest risk of injury to the nerve.
Okay.
And another thing which is to be followed is the supinator should be elevated subperiosteally,
Perfect.
that the risk of injury is minimized.
Great. Yeah. The others now can take over. Well done. Nice.
Yeah. So, yeah, I would also agree with sir that your presentation is very crisp and absolutely to the point.
Thank you, sir.
As far as the approaches are concerned, you said the advantages of doing a Kaplan is that you can tackle a terrible triad also, which, yes, of course, is an added advantage. So if there is a terrible triad, if there is a coronoid fracture, how would you approach that using the same Kaplan's approach? Would you take a separate incision, or would you just extend this one and go on the coronoid?
Sir, usually in case of a terrible triad, the radial head, to approach the coronoid, the radial head fragments usually need to be removed first. So I would go with the same approach and remove the radial head fragments. If there is a lot of combination, then approach the coronoid, fix the coronoid, and then again go to the fixation of the radial head, or replacement as determined by the fracture pattern, and finally fix the tone or the avulsed lateral collateral ligament complex.
Yeah, and one more question regarding replacement of a plate fixation versus screw fixation of a radial head. What is the current recommendation in literature? Whether you use a plate preferably or a screw, and which results are better?
Yes, sir. The plate is mainly used when there is an associated radial neck fracture. But as per the review which I did, the low profile screw fixation is now getting more response. Basically it involves the use of screws to fix the head to the neck. And the study which I showed, they had compared 3 constructs, and they found out that the greatest stiffness was when 2 crossed screws were used for fixing the head to the neck. The plate had the least amount of stiffness, and obviously the plate is associated with more dissection, more risk of damage to the nerve, as well as the increased risk of implant removal. So low profile screw fixation is the treatment which is nowadays being preferred for managing neck fractures as well.
Can I just ask something? Just extension of Dr. Harshad's question. You said that you would take out the head radius and then approach coronoid. Is there anything written in that paper which tells you that you can approach coronoid? I think that is one point they mention in that paper as to
Yes, the
approaching the
proximal
coronoid
extension,
using this.
proximal extension of the Kaplan's approach can also help in visualization of the coronoid, which is not provided by the Cocker's approach.
That's right. How do you proximally go? Up to where do you go?
Proximally around, I would extend it proximal to the lateral epicondyle and have a dissection to get to the coronoid.
Good, good. Sorry to interrupt.
Sorry.
Dr. Dhar and Ashish.
Ashish, you can go ahead.
Right, right, Rudra. So good presentation, a lot of information to take in, and a very good topic. I wanted to ask two questions.
Yes.
But in amongst all the studies that you have reviewed, was there any study which now deals with anatomy of the posterior interosseous nerve with regards to do the cadaveric dissection studies, which tells you how best to keep it safe in the various injuries that you have?
Yes, sir.
And
So
the
in
second part was your title discusses your title says the current techniques and outcomes, right? So you told us what the recommendations are, but are there any differences in the outcomes of the different modalities of fixation in the long term, and which are associated with higher incidence of reoperations?
Yes, sir. Sir, initially in the cadaveric study, which I had shown in the presentation, they have mentioned the technique to prevent damage to the posterior interosseous nerve. So the study says that although the Kaplan approach is associated with more risk of injury to the PIN, it passes through the supinator muscle, and keeping the arm in pronation is the main step. But the other important point is subperiostally elevating the supinator muscle. So this is one thing which they have mentioned, which will avoid direct contact and handling of the nerve and will decrease the risk of injury to the nerve. And sir, secondly, regarding the different studies which I have reviewed, most of the studies, the long-term follow-up with the radial head arthroplasty is currently not available, but the mid-term and the short-term outcomes are available. So most of the studies recommend the basic principle that type 1 fractures should be managed non-operatively, Mason type 1. Mason type 2 fractures can be managed with open reduction, internal fixation, or conservatively. It is more dependent upon the number of fragments. And type 3 fractures, the most important recommendation now is to manage them with radial head arthroplasty, not go for open reduction, internal fixation, especially when there are more than 3 fragments and when there is comminution. And radial head resection is only to be preferred in patients who are old, basically more than 65 years of age. And it should not be done in the presence of associated injuries, as it can lead to increased incidence of elbow instability.
Okay. Excellent.
Okay. Thank you, judges. And thank you, Rudra. Now I
Thank you,
invite Dr. Shahrukh Khan for sharing his presentation. Yeah, we can see it.
Good evening, everyone. Shall I start?
Just make it full screen.
Yeah.
Yeah, you can start now.
Am I audible, sir?
Yeah, you're audible. Your screen is visible. Go ahead.
Okay. Okay. Good evening, everybody. We are I'm going to discuss about the plate fixation versus intramedullary nailing in humerus shaft fractures today. My name is Dr. Shahrukh. I am a senior resident from Lok Nayak Hospital and Maulana Azad Medical College. The incidence of shaft humerus fracture is 1 to 5% of all fractures, which amounts to around 13 to 20 per lakh population. It has a bimodal presentation. The complications are malunion, non-union, and radial nerve injury. I'm just touching upon the conservative management to tell about the importance of this talk. The conservative management is done by bracing for 10 to 12 weeks. In humerus, malunion is acceptable to a high degree. There is high rate of non-union, high rate of shoulder and elbow stiffness related to conservative management. The overall union rate is around 83%, which is further just 76% in the proximal 1/3 of the humerus fractures. The risk factors for non-union are smoking, female sex, initial displacement of the fracture, old age more than 55, and the transverse and oblique fractures have a lower union rate compared to comminuted fractures. Coming to methodology for this study, the objective of this study was to review literature on surgical management of shaft humerus fractures using plating and nailing. This terms shaft humerus fractures, plate, intramedullary nail, and randomized controlled trials were searched on PubMed and for last 10-year studies, and the studies which were related to plating and nailing of shaft humerus fractures and minimal invasive plating of the shaft humerus fractures, and which were RCTs were included. Retrospective studies and case reports were excluded from this study, and I have included 3 studies which were comparing open plating versus nailing, 2 studies which compared minimal invasive plating versus open plating, and 2 studies which compared minimal invasive plating with intramedullary nailing. These are the surgical indications of the humerus fracture. The surgical treatment options are open reduction and internal fixation, which is also known as open reduction and plate osteosynthesis. I will be calling this open plating, intramedullary nailing, and minimal invasive plating. The open plating is done by anterolateral approach in the upper and middle 1/3 of the humerus fracture. The lower 1/3 humerus fractures are approached by a posterior approach. A 4.5 mm plate should be applied, and at least 8 cortices or 4 screws should be applied on either side of the fracture. The locking screws are preferable in only the weaker bones. The open plating is associated with 87 to 96% of union rates, but the complication rates are very high. They are 5 to 25%. The main complications are infection, non-union, which is due to stripping of soft tissues and malreduction, malunion, hardware failure, and there is a high risk of iatrogenic radial nerve palsy, which is highest in the posterior approach. Coming to nailing, intramedullary nailing is done by a deltoid split approach in which the rotator cuff muscle supraspinatus is also split. The entry is made between greater trochanter and articular surface of the humerus. Reduction of the fracture is done and the guide wire is passed. Reaming is done only in the proximal part. However, in the young patients, reaming of the canal can also be done, but it is associated with higher risk of radial nerve injury. The nail is passed. A short size of nail should be passed because the longer nails are associated with distraction of the fracture site and impingement at the shoulder joint. The proximal locking is done and followed by distal locking. And distal locking is done in the AP anteroposterior direction, which is safer. Intramedullary nailing is associated with 86 to 100% union, and the non-union is associated due to fracture distraction due to a long nail. There are very high shoulder complications which is due to a prominent nail which causes subacromial trauma and rotator cuff damage. This can cause impingement, loss of motion at the shoulder joint, and loss of strength. Coming to minimal invasive plating, 2 incisions are given. The proximal incision is in the distal deltopectoral interval, and another incision is given distally, which is 5 centimeter proximal to the elbow crease. A 12-hole plate is used, which is slided from proximal to distal end under C-arm guidance, and 3 screws are applied on each side. The plate is slid between the biceps and the brachialis muscle, which prevents injury to the radial nerve, which lies between the brachialis and the brachioradialis muscle. In the distal incision, the cutaneous nerve of forearm and muscular cutaneous nerve should be, the injury should be prevented. The post-operative care is same for all these 3, which is shoulder range of motion exercises, active and active assisted exercises, post-op weight restriction till 3 months, and if the patient is using crutches, it should be used as tolerated. These are 3 RCTs which are comparing open plating with intramedullary nailing. In all these 3 studies, the infection rates were higher in the open plating, but the shoulder function was worse in the intramedullary nailing technique. These 2 studies compare minimal invasive plating with intramedullary nailing, the rate of non-union and iatrogenic nerve palsy was higher in the intramedullary nailing compared to minimal invasive plating, while the infection rates and functional outcome were same. These two studies are comparing minimal invasive plating with open plating, and there is a high risk of iatrogenic radial nerve palsy in the open plating as compared to minimal invasive plating, and the infection and non-union rates were also higher in the open plating, while the functional outcome was same in both. This is a meta-analysis which shows different aspects of the related to minimal invasive plating, open plating, intramedullary nailing, and non-operative treatment. The non-union rates are higher in the in the intramedullary nailing and non-operative treatment, while they are lowest in the minimal invasive plating. Iatrogenic nerve palsy is higher in the intramedullary nailing and the open plating, while they are low in minimal invasive plating. The infection rates were also high in the open plating, and the functional outcome was best seen in the minimal invasive plating, while it was worst in the non-operative treatment and intramedullary nailing. The conclusion of this review is that the plating has a high risk of infection, intramedullary nail has a high risk of shoulder problems, and minimal invasive plating has better results than both in terms of functional outcome and lower incidence of radial nerve injury. These are the references which I have used for this study. Thank you for this opportunity.
Thank you, Dr. Shahrukh. You too finished with 4 seconds left. So that's my timer. So nice study, and let's go ahead with judges to ask questions. Over to you, Agashism.
Sir, Sanjay Dhar is there, I think.
Yes, sir.
Dr. Dhar,
Yes, sir.
would you like to ask?
No, it is your privilege.
Discuss. Okay. Okay.
I'm just
Very well done, Shahrukh. I think
you.
all two were, sorry, two of them. Third, we have to, he's still to present, but both of you have done a good job. Now, a couple of questions. You said short nail. How do you define short nail?
Sir, the nail should not be protruding into the subacromial space, and it should be around 5 centimeter, at least 5 centimeter above the tip of the lateral epicondyle, sir.
Tip of the lateral epicondyle.
Lateral.
Okay. I believe from your diagram, you said you pass the plate between brachialis and biceps.
Yes, sir.
For minimally invasive. That is
Yes.
where you put your plate between brachialis and biceps.
Sir, it is put at on the anterior surface, slid on the anterior surface, and between these two muscles.
Between these two muscles.
Yes, sir.
So, which nerve passes between these two muscles?
Sir, musculocutaneous and.
So, if you put the plate between brachialis and biceps, it would be reasonably away from the bone, and you are very likely to injure this nerve, isn't it?
Sir, it is said in these studies that if you supinate the forearm completely, then there is very low risk of injury to both radial nerve and musculocutaneous nerve.
Okay. Now, which nail have you been talking about? Is it the new multi-lock nail or the old one?
Sir, one study was on the old nail, and 2 studies were for the interlock nail, which is newer one. So.
Okay. Thank you.
Thank you.
Over to
Ashish, you can go ahead with your questions.
Yeah. So Shahrukh, if you were to have a nail or a plate, if you were to have a fracture humerus, what would you choose?
Sir, it will depend on the fracture. The intramedullary nails are preferred in the segmental fractures and the pathological fractures. So I would keep the nail for those fractures only. And I would like to go for a minimal invasive plating if there is a mid-shaft fracture. And depending upon the fracture morphology, I will use open plating if there is a combination of or if there is a extension into the joint. That is,
But when they have compared the papers, they have compared a particular fracture type, isn't it?
yes, sir. Most of the fractures were, sir, middle 1/3 transverse fractures were compared in most of the studies, sir.
Did any one of them have a preoperative palsy?
Sir, most of the studies they have excluded, all the studies which I have included, they have excluded the pre-op radial nerve palsies in all these patients because they were checking for the iatrogenic radial nerve palsy. So I've excluded those studies, sir.
And in which of the treatment modalities is your risk of reoperation higher?
Sir, risk of reoperation is highest in the intramedullary nails because the non-union rates due to distraction are higher. And sir, there is a need to remove the nail because of subacromial impingement. These were the two indications due to which repeat surgery was done, sir. And the second was the open plating. Yes, sir.
As regards to the post-operative radial nerve palsies or post-operative palsies, which of the three modalities was a re-exploration required?
Sir,
studies?
Sir, in the cases where of intramedullary nails, the second treatment was to apply a plate and remove the nail. So they have explored radial nerve, otherwise it was not required, and most of them were treated conservatively only.
Okay. Excellent. I think that's
Dhar, sir, any
good
questions?
Yeah, Shahrukh, I think I am not sure whether you presented any literature on, I mean, the types of fractures like plating we generally tend to use for very transverse fractures, nailing we try to use for comminuted. So could you find anything in the literature? And you have not said anything about mal rotation in such fractures. So could you find anything in the literature regarding that? Because generally my indication would for a nailing would be a comminuted shaft fracture where you can't do a good plating. So could you find results of such fractures or could you segregate them in the literature?
Sir, I just found that the segmental fractures have a better result with a nail. And if the fracture is severely comminuted, then it is better to go for a non-operative treatment in these patients.
So are there any guidelines which you could find in the literature regarding these indications?
No, sir.
And anything about any pre-contoured plates you could check? There were earlier times when we could even Synthes had come out with a pre-contoured plate, which is a curved plate.
Sir, there was no mention of pre-contoured plates in the middle 1/3. They just have talked about it in the distal humerus fractures, which had articular combination.
Okay.
To continue that question, what about mal rotation? In which modality the mal rotation has been more?
Sir, there was no mention of any this particular complication, and because the intermedullary nails, they are locked, so they do not tend to mal rotate post-operatively.
No, that is not
that is not the
right
thing.
Sir,
it doesn't.
Mal rotation occurs at the time of reduction. It's not after the blocking.
Okay, sir.
Mal rotation is hidden by the fact that the shoulder is allowing more movement. So it may not be evident that mal rotation has occurred with a nail. It's quite common with a nail. You might get extreme rotations, one side more and the other side less, which will detect this kind of mal rotated. With a plating, the mal rotation is less likely.
Sir, there was no mention of mal rotation in these studies, and they've just talked about the functional outcomes using the UCLA and ASES scores.
I believe I just suggest to read more about the MIPO technique.
Okay, sir.
This paper which you have quoted does tell you a bit more.
Yeah, sure. Yeah.
But well done. Well done.
Thank you, sir.
Okay. Thank you, Dr. Shahrukh, and thank you, the judges. Let's
Thank
move
you,
on to our next contestant, Dr. Vasav Somani. You can share your presentation. Yeah. Okay, we can see. You're muted, Vasav. just unmute yourself.
I'll just unmute myself. Yes, sir.
Okay, we can hear you.
Is my
Presentation.
yeah.
Go ahead.
Good evening, everyone. Yeah, I'm Dr. Vasav Somani, senior resident at KM Hospital. I would like to take this opportunity to thank Bombay Orthopaedic Society for providing me this opportunity to present on this platform. My topic of presentation is Monteggia surgical techniques and outcome. So Monteggia fracture was first described by Giovanni Battista Monteggia in 1814, where he described the lesion as a traumatic fracture of a proximal third of ulna and an anterior dislocation of proximal epiphysis of radius. This was later on described by Jose Luis Bardo, where he gave the Bardo classification and further described the Monteggia lesions and Monteggia equivalence. He classified the Monteggia lesions as type 1, 2, 3, 4, where type 1 is anterior dislocation of proximal radius with the shaft of ulna fracture. Then there is type 2 is posterior dislocation of radius. Then there is type 3 is lateral dislocation of radius, radial head, and type 4 is anterior dislocation of radius with the fracture of both radius and ulna. So my methodology for today's presentation has been an electronic database search, which includes PubMed and Google Scholar articles with the studies which are relevant in the last 10 years. References list of selected articles were assessed to include any other relevant studies. Studies with the high citation index were chosen for the narrative review. So why are Monteggia lesions important? Although the incidence of Monteggia lesions among the pediatric elbow fractures is 2%, the incidence of missed Monteggia and incidence of the rate of Monteggia revisions is almost 10 times higher than the incidence. So that is why we need to focus on the Monteggia lesions. So the key radiologic finding is the loss of radiocapitular relationship. The Smith in this first study mentioned that the radiocapitular lesion, line should pass through the capitulum. He does not mention anywhere that it should bisect the capitulum. And the recent literature also questions the validity of this finding that when a line is drawn along the radial shaft, it misses the capitulum in a 16% radiograph of normal elbows. So in also the most consistent radiocapitular line is drawn along the radial neck on lateral view. This has been mentioned because in literature there has been confusion whether the line is to be drawn from the radial neck or the radial shaft. So what are the two principles of fixation? The two principles of fixation for Monteggia lesions are stable elbow joint and a stable fixation of ulna, restoring the ulnar length by stable fixation. So we have this three-step approach to approach the Monteggia fracture, which has been mentioned in the injury journal in an article in 2021, where they have identified the Monteggia lesion based on radiograph. And further, they have assessed the ulnar fracture pattern. This ulnar fracture pattern may be incomplete or a complete fracture pattern. The incomplete fracture pattern may be a plastic deformation of a ulna or a green stick fracture, which can be managed by close reduction and above elbow cast. Then we move on to the complete fractures of ulna, which may be a length stable or a length unstable fracture. The length unstable may be a transverse or a short oblique fracture, which can be managed by intramedullary nailing, whereas the length unstable fracture may be long oblique or a comminuted fracture, which are managed by open reduction, internal fixation with plating. Okay, so this algorithm, if we keep in mind, there has been a study by Ramsky et al. In a Journal of Pediatric Orthopedics in 2015, where they carried out a multicentric examination of treatment strategy. They have taken a sample of 112 pediatric Monteggia fracture patients, and they have followed the previously mentioned algorithm, where if we follow the treatment strategies mentioned in the algorithm, and if we become aggressive as compared to the strategy, there are no failures. However, if we become less aggressive and does not follow the strategy that has been mentioned, so there are high chances of failure in the study. So this study points out that there is importance of surgical management of Monteggia fractures, and one can become aggressive when in doubt. 6 tips to not mess up the pediatric Monteggia fractures are: we need to obtain optimal radiographs, a full-length radiograph of a forearm with the elbow, because there are high chances of missing the radial head dislocation. One should be aware of a differential diagnosis of congenital radial head dislocation. One should identify the unusual Monteggia fractures, and once we are in doubt, we should go ahead with the fixation rather than a conservative management, because there are high chances of late dislocation. Hence, one should obtain a weekly radiograph, and one should be aware of nerve injuries. Here we complete these pediatric Monteggia fractures. There is a difference between the pediatric and adult Monteggia fractures. Hence, Jupiter has further elaborated on the Bardo's type 2 Monteggia fracture classification. So this Jupiter classification helps us divide the surgical management of Monteggia fractures and also helps us prognosticate the outcome. He has divided the type 2 Bardo fracture into type 2A, 2B, 2C, and 2D. Type 2A is a fracture of the proximal ulna, including the coronoid. Type 2B is a fracture distal to ulna, which does not include coronoid. Type 2C is a diaphyseal fracture of ulna. Type 2D is a diaphyseal metaphyseal combination of ulna with a fracture of coronoid. So two important considerations that are to be kept in mind while fixing the proximal ulna is the two anatomical parameters, which are proximal ulnar deviation angle, which has been due to anterior tilt of the proximal ulna, and a varus angulation of ulna. The current devices that have been come into existence are the locking compression plate, which are the anatomical plate, they are designed in such a way that these two parameters are kept in mind. And once these are followed, adequate fixation of proximal ulna is possible. And the recent study also emphasizes on the fixation of proximal ulna using a locking compression plate, which has a less revision and a less rate of ulnar non-union as compared to the non-locking compression plate. Now, the common algorithm that I found while managing the complex adult Monteggia fracture is this one: we follow a posterior midline approach. We begin by reconstruction or replacement of radial head, which is then followed by stabilization of ulnar shaft, including the coronary process. This following the stabilization of ulnar shaft is then fixed to the olecranon. Once adequate restoration of ulnar length is achieved, we can reduce the reconstructed or replaced radial head to the radiocapitular joint. And a coronal plane instability may be assessed. Any instability may then later on be addressed lastly. So the outcomes for the complex adult Monteggia fractures have been assessed based on the classification, scores, radial head, ulnar non-union, and associated injuries. In a study from Journal of Bone and Joint Surgery, Conrad et al. In 2017 have assessed the long-term results and prognostic factors following a patient sample of 47 over a period of 8.4 years. And he has found out that there is poor prognostic value of Pardo type 2, and in them the Jupiter type 2A and 2D has a poor prognostic value. The only drawback while assessing this long-term results are there was no prosthetic replacement that was carried out in this study. Another study from Journal of Bone and Joint Surgery, Young et al. In 2018 have provided midterm results of 46 cases. He had produced good to excellent midterm results in separate clinical entities. The advantage of this study, he has clearly defined the Monteggia lesion, and this is the largest sample which have been defined clearly, and all the outcomes have been assessed separately. Although there is a controversy in management of radial head fractures and its outcomes, because there are multiple the studies in the literature have proposed a controversial management. Two studies that are found out have a comparable period of follow-up. One by Matar et al. In 2017, he has mentioned that the functional outcome is not affected by the severity of radial head fracture. By Klug et al. In 2019 has presented an article in Bone and Joint Journal where he has mentioned that the Mason type 3 fracture and the associated coronary fracture that have been managed by radial head arthroplasty have poorer outcome. This study emphasizes that the replacement is more favored than excision, and the study by Klug et al. In 2019 mentioned that the excision more than replacement. Hence, there is a controversy in the literature regarding the management of radial head in a patient with complex Monteggia injuries. Also, we have a study where they have where Young et al. In 2020 have assessed the midterm outcomes of a Monteggia-like lesions with the radial head arthroplasty, and he has achieved satisfactory result. However, the complication rates and revisions rates are very high. Although now we would like to consider the poor prognostic factor that helps us in determining the outcomes. So the Bardo type 2, Jupiter type A, SX low pressure injuries, associated coronary and radial head fracture, and ulnar non-union are the poor prognostic factors. So I'd like to end my presentation with the thought that observation is not enough. One must think, and observation without thought is as dangerous as thought without observation. This is by Jose Luis Pardo, and these are my list of references.
Thank you, Dr. Vasav. You two finished in time with few seconds left. Over to judges for questions. Agashi sir, you can start.
Great presentation, Vasu. A couple of questions. How common are these Monteggia variants? You said that you need to be careful about Monteggia variant. How common are they?
So
there
the
anything?
thing with the Monteggia, okay, yes sir.
Is there anything in the literature which tells you how common are these Monteggia variants?
So the problem with the Monteggia variants is that there are no clearly defined Monteggia lesions, and also there are possibility of high chance of misdiagnosis concerning the complex adult Monteggia injuries, and there is no proper incidence that has been reported concerning this complex variant of adult Monteggia injuries.
Okay, let me specify pediatric variants.
Okay.
I mean, there has been a paper where they have said that Monteggia variants occur far more frequently than classic Monteggia. Okay. Now, secondly, in the theater, after you have fixed your ulna, what would you do? What would be your first step? You have fixed the ulna. Now, what would you do?
Okay. I would check for the adequate stability of ulna, and once I would check the stability of ulna, I would see whether the radial head has automatically comes into place following the reconstruction, and whether there is adequate contact of the radial head with the segment notch or the segment notch of the ulna. So that helps us in determining that we have adequately fixed the coronoid and the radiocapitular joint stability has also been restored. Following that,
how will you see that? If you are fixing only the ulna, you're not exposing the radius, isn't it? Generally. So how will you do that?
okay. I would take prefer a Boyd's approach in order to see both the olecranon and the radial head simultaneously.
Okay. Is there anything? Suppose you have fixed only the ulna, exposed and fixed the ulna.
Okay.
What all views will you take? Because that is something that is mentioned in the literature. As to what views do you take to confirm that the radial head is there in place? Not an issue. I think Harshad would like to ask something.
Yeah, see, just one observation, Somani, that you had a lot of material which you're trying to present in 8 minutes. I do understand that it's a very broad topic, but you're talking too rapidly. Sometimes difficult to understand what you're trying to convey. So try and at least curtail your content so that it becomes a little more audible and a little more understandable. This is just general. Otherwise, the matter inside your presentation was pretty good. And the questions asked by Agashi sir are quite relevant. How do you determine intraoperatively whether you need to do something for the radial head and or whether you need to leave it alone? Is a very important question which you have to answer. And for that to get intraoperative views to understand that the radial head is actually back in place, because you did mention the two lines, but it was an inconclusive argument. Which is the final line which you would consider to understand that your radial head is now back in relation with the capitulum as what it should be? That has been left open.
Okay.
Yeah, you can go ahead and answer.
So it is, I think it is the radiocapitular line that we need to assess on a lateral view. That helps us to determine if the radial head, the line drawn from the radial neck to the capitulum, if it just intersects the capitulum, we can confirm that our radial head is back in place, and the ulna anatomical configuration of ulna has also been restored.
Suppose it is not there, then what would you do? You fix the ulna, the radial head is not falling into the parameter which you wanted. Then what is your next step?
Okay, so maybe sir, I'll look at the Shyam intraoperative fluoroscopy shoots of the ulna, and maybe if I say I have not restored the proximal anatomical configuration of ulna, that is the only reason that it might not come into place. Because if you have adequately restored the anatomical configuration of ulna, the radial head automatically falls in place.
Generally, once you restore the length and angulation of the ulna, your radial head should fall back in place. So you have to check if there is a rotational malalignment or whether you have made the ulna a little shorter than what it should be, especially if there is a comminuted segment. Ashish can ask the question.
Right. So a lot of material to take in, as Dr. Harshad said. Yeah, it's a vast topic, but yes, try to space it out for the lack of time. I wanted to ask something regarding adult Monteggia variants. I mean, sir said that they are very common. There was a slide where you mentioned in adult Monteggia, then they have fixed the radial head first, and then they have gone on to fix the olecranon. Is that correct what you said?
Sir, that is the, actually I looked up the literature, and that is the most common algorithm that I had come across. That you begin your fixation by posterior approach and start fixing the reconstructing the radial head. And if it is not possible, you go ahead with the replacement and then start fixing the ulna and the coronoid. That is what I had come across in the literature. Because it was a bit controversial, so I could not gather there was no review article or anything that could lead me to a proper approach, as in how to approach the complex variants.
Okay.
Dhar sir, any questions?
Not really. So regarding this Essex Lopresti type, where there's disruption of the interosseous membrane. Could you find any literature? How do you assess them? How do you isolate such injuries and their long-term results? Because we always talk about that, but I am at least not able to preoperatively see them clinically. Could you find any literature?
No, sir, because those injuries that the literature that I had come across were where such case reports only. There were no review articles that were available because most of these lesions are not reported only. So I could not gather a proper article which has adequate strength in order to represent it here. So,
Okay. Any role of MRI or any such injuries? You could find any literature?
No, sir. I did not.
Regarding delayed presentation, did you study anything about delayed presentation of these fractures where the radial head has been out for some time, and yet if you fix ulna, whether fixation is the same algorithm works for them also?
Possible, but the literature that I had come across is after 2 weeks, it is very difficult to have the radial head in place following a conservative management. We need to have an aggressive approach where we need to fix the ulna, and in order to restore the radial head back in place, if it is anteriorly translated, we need to do an angulation osteotomy of the ulna posteriorly so that the radial head following that angulation comes in place.
Okay. Okay. Thank you.
Great.
Okay.
So just to answer,
Yeah.
just to answer my question, what is important, very often after plating the ulna, you take a Shyam shoot like this. And what is important is you must rotate the forearm in full pronation and supination, and very often it dislocates in pronation. So that is something you have to remember.
Okay.
Okay. I have just one comment about the presentation. So you said you selected the article by high citation index. The articles don't have citation indexes. It's the authors that have citation index. Keep in mind that. Okay. Thank you, Dr. Vasav, and thank you all judges. Over to Dhar sir for closing remarks, and also invite the judges for their comments on the program.
Yeah, they can. Thank you very much, Agashe sir, Ashish and Harshad. Thank you. We always look forward to your presence in this session. We will have more for the second round also. So thank you very much. And thank you all the participants for presenting nice presentations. So over back to judges. Agashe sir for your concluding remarks.
At the outset, I must congratulate Dr. Dhar, Dr. Ashok and Dr. Neeraj for this great idea. The conceptualization was really good. Secondly, I really congratulate all the three presenters for excellent presentation. The way they presented, the way they answered was fantastic. You are much, much better than what I was when I was your age. Much better. Well done. Or probably you are better than me even today. Well done.
No, I do agree with sir. The presentations were really, really excellent. You do require a little bit of polishing to, reach levels where the senior people have taken years and years and years to reach. So I think this is a good stepping stone and a good idea by the present BOS EC team led by Sanjay Dhar to pick out such people from our community and give them a platform on which they can present their skills rather than, having them to struggle the whole way, which most of us have had to do. So this is a good opportunity and I can see that people are making good use of it.
Ashish.
Excellent. Thank you very much, sir, for making me a part of it. But it's quite, very encouraging and pleasing to see the energy that these people bring in. So Rudra, Vasav and Shahrukh, hats off for the effort that you have put in. Very good. And as you go along and you'll realize that, you don't need to, fill in the 28 slides or so, 8-minute presentation could have been in only 14 slides or 16 slides at the most. I would have preferred to see sort of maybe a larger font, a different shade, a black lettering on a white background and things like that. But those are not very, very important. What was also important is that you're competing for the rising star, and all of you are stars. You will rise very high. But I also wanted to see your opinion on that. You're presenting a literature review as a rising star, and in the end you say, okay, this is what I read, and this is what I think I would take it from that. Like I asked you a question, if you have to have a fracture humerus, what would you choose? And you said, if I have to have a fracture humerus, which is a simple transverse, I would get it plated or something like that. A very clear message at the end of it. Because ultimately this will go on YouTube, people will watch that, and you will be stars. We hope to see you in Vairog.
Thanks, Dr. Ashish.
I hope you are coming for Vairog, all of you.
Yeah, they will all be.
Sir, sun nahi rahe.
Dr. Neeraj, are you around?
Yes.
Yeah, over to you.
Yeah, so it was fantastic. These are the three common fractures which you will see on a day-to-day basis. And I fully agree with Ashish that basically all of you who are going to be the future presenters maybe can include that. And do see the video which was posted in the group of Dr. Dhiren Ganjwala, which was taken on Vairog Global, to see how to make a better presentation in the future. So with this, we close today's session. Thank you, and hope to see all of you
Thank you
in
very
the
much.
next session.
Thank you very much.
Thank
Thank
Good
you.
night.
Thank you. Good luck.
Thank you. Bye-bye.
Thank you.
sir.
Bye. Bye. Well done.
Okay.
Bye.
Bye.